Nagul sir, do you want to comment on
I
that?
was saying that we can move on to the next case in the interest of time. I believe we have 2 or 3 more cases left. So, can the technical team put on the next case? I think
I'm Dr. PLN Kapardhi, Senior Interventional Cardiologist from Care Hospitals, Hyderabad. So today I am presenting an interesting case of Shepherd-Crook calcific right coronary artery, how OCT guided my angioplasty to diagnose the morphology as well as the optimizing the result. So the history is as follows. A 69 years old gentleman, risk factors of hypertension, diabetes, and dyslipidemia, and he underwent angioplasty to mid-segment of right coronary artery in 2009 for inferior LMI as a primary angioplasty. And till now, he is totally asymptomatic, and he presented with chest pain and breathlessness. And ECG showing a evolved inferior wall MI with endoped of more than 24 hours. And he was hemodynamic unstable. He was stabilized by intra-aortic balloon counter pulsations. And his LV function was improved to 45%. And his baseline angiogram was shown left coronary artery, both LAD and circumflex are diffusely diseased with normal left main. And then right coronary artery is showing an interesting finding of Shepherd-Crook RCA with a distal RCA segment is calcified with a lot of hazy lesions with patent mid-segment stent. And then we have taken a Judkins 6 French right coronary artery catheter, and then we passed the workhorse wire that is run through across the distal segment lesion, and wire was parked in the PLV. And next what we did is as a part of routine that to reveal that hazy lesions, we passed the OCT but is unable to cross across that hazy lesion. So it indicates that the lesion was adequately prepared. So we have taken 2 into 10 mm balloon and then dilated that distal segment of RCA. By dilating, the balloon was ruptured. Then we have taken other balloon and then dilated. Then we subsequently passed the OCT catheter successfully, and when we are taking the run, the lens was stuck in the hazy zone, and then we abandoned that one, and we have taken higher size balloon, the 2.5 into 10 mm, and then systematically dilated the lesion. And then subsequently, after adequate dilatation with the 2.5 higher size balloon, we followed we did the OCT and followed the modern OCT guided PCI workflow, that is MLD marks. And as the protocol pre-PCI morphology length and diameter, after taking the run, the OCT findings are as follows. The distal hazy lesions are caused by means of the admixture of white and red thrombi, and proximal hazy lesion, it is caused by protruding calcific nodule at 6 o'clock position, as well as the calcific erupted calcific nodule with a spicule at the position. And then this is a OCT and angio correlation showing the same thing, distal hazy by thrombi and proximal hazy lesions by protruding calcific nodules. Then the measurements, it is at the tightest lesion, the area is 1.6 square millimeter with a vessel diameter of 2.0 millimeters. And then subsequently, after lesion preparation, we want to pass the stent 2.75 into 28 millimeters Janes with the help of the guide Gilla, that is a mother and child in the 6 French guide catheter, but unable to negotiate, and ultimately the entire design came back. As an alternative strategy, we have taken the 7 French amplage and with the help of the buddy wire, and then we successfully negotiated across the distal lesion, and then we deployed that balloon stent across the distal lesion. And then we did post-stent dilatation, that is 2.5 to 10 mm, the entire distal segment of the lesion, including the overlap. And then as a part of post-PCI OCT, we want to optimize, that is edge dissections and opposition expansion we want to analyze. And it is showing no edge dissections at the distal and the proximal segments. And then it is adequately dilated, but the expansion rate is only 72%, indicating it is much more we have to dilate the vessel. And we subsequently dilated with a 3 to 10 mm balloon dilatation, and then optimize the results. And at the lesion site where the nodule is there, the gain of the area from 1.7 to 4.5 square millimeter, almost a vessel reaching 2 square millimeter, vessel diameter 2.9 millimeter, and distally the gain is 5.8 millimeters, and proximally it is 6.7 square millimeter. So indicating the almost we optimized with adequate expansion as well as no malpositions. And then this is the pre-PCI post-PCI minimal luminal area. Distally from 3.5 to 5.8, and at the lesion site 1.7 to 4.5 square millimeter, proximally from 4.1 square millimeter to 6.7 square millimeter, indicating adequate minimal stent area gain. And this is the final result, indicating a good T3 flow without any under expansion. And take home message from this complex cases: acute coronary syndrome can be due to plaque rupture, erosion, and calcific nodules. Image guide, especially OCT, helps to understand the etiology of the acute coronary syndrome. In this present case, OCT revealed a calcific nodule protruding and also which is the cause for the attracting the thrombus and ACS. And Shepherd Crook RCA with calcific distal segment produced the difficulties in OCT catheter crossing and a long segment negotiation. And Amplage along with the Buddy wire provide the very good support. And OCT helps in analyzing the lesion morphology, vessel diameter, and length of the lesion. And post PCI is very useful to analyze the stent expansion, opposing edge dissections, which play a significant role both in acute as well as the long-term outcomes. Thank you.
Thank you. The success of a PCI in a Shepherd Crook's RCA is based on the guide catheter support you can achieve. And RCA catheter cannot give a good support in a Shepherd Crook's RCA. And when you change from the RCA catheter, the Judkins, to the implants, it made the whole difference. I think it was the support that provided by the implants helps you to push in all the devices. Otherwise, even despite the use of a guide extension catheter, you found it extremely difficult to negotiate your devices. How did you manage that calcific nodule without stent under expansion? I thought that calcified nodule had a rupture and with a few small thrombi that is attached to the cap. I think there were the calcified nodule has ruptured and produced something like a plaque rupture and thrombus, which led to the acute coronary syndrome. Normally, it is extremely difficult to crack the calcific nodule.
Actually, I want to explain some of the important natural history of calcific nodule at this juncture on OCT imaging. So naturally, if you take the coronary calcification, first it starts as a stippled calcification, the healing process, then they will coalesce, then it forms superficial lake, then it will protrude in the lumen. So they may be a soft type of nodules which can heal by NC balloons, and sometimes as the time goes on it becomes hard and it won't yield with routine NC and balloons, but it needs a rotablation to ablate when the wire bias is there, or a prolonged IVL inflations, prolonged IVL the energies to cause fractures. And see, this is the natural history, but here it looks like a relatively not so much hard, and it yielded to a higher size routine NC balloons, even the not opium balloon also. But during this process, we lost one of the balloon rupture also because of the eruptive nodules with spicule. But it is a fortunate, but the haziness lesions makes the, I am a little bit overconfident. It is the Shepherd Crook also, it is not mild rather than a severe Shepherd Crook. So that's why I underestimated the curve. At the same time, the lesions, because of hazy on one side tight, and the calcification also fluoroscopically not looking like a severe calcification, taking rota like that is not there. So underestimated fluoroscopically in the lesion. So I have to put the caster so that the stent I came back. Then I took the extra support and finished the stent delivery, and then a higher size 3 mm by dilatation with a good expansion at the calcific site.
You are quite lucky that the calcium nodule could be, you could crack the calcium nodule with a normal high pressure balloon.
I think it was a very friendly calcific nodule.
Very friendly.
It's not,
Otherwise,
yeah.
even IVL is not a good option. Even Rota is not a good
No,
option for
no,
calcific nodule. Orbital atherectomy may be
In
the
fact,
best
I would say OPN balloon should be tried because I mean it has at least the advantage of not going over its size, whatever
Yes.
you do with that. So even if you go up to 50 atmospheres, it doesn't go over more than hardly 5% of its size. But you're right, it was a nice result. And I mean, okay, try whatever you want and keep on trying one by one, whatever you have, whatever is available, whatever is affordable, and let's hope for the best. Thank you.
Thank you.
Thank you, Dr. Kapardhi.
Thank you.
Yeah.